Assalamu alaikum wa rahmatullahi wa barakatuh. Today we are going to talk about pathology of bronchial asthma. I'm Dr. Khadiga Muhammad Ali. I'm an assistant professor of pathology. In our lecture today, we are going to talk about the definition, pathologic types, pathogenesis of bronchial asthma, microscopic examination, and complication. To start with the definition of bronchial asthma. Bronchial asthma it is a chronic inflammatory disease of the airway. It is characterized by recurrent attacks of widespread bronchoconstriction. Bronchoconstriction, we call it airway hyperresponsiveness in response to various stimuli. It is one of the obstructive pulmonary diseases. Bronchial asthma is classified according to the etiology into two types, either extrinsic or intrinsic asthma. In case of extrinsic asthma, we call it the allergic, the immunologic, or the atopic asthma. It represents about 10% of the cases. It is more common in children and young individuals. This type of asthma is associated with a positive family history, genetic history of asthma or allergic disease. The attack is caused by type 1 hypersensitivity reaction in response to inhaled allergen, such as house animal dandruff, plant pollen, and fungi, among others. In this type of asthma, serum level is increased. While in intrinsic, the non-atopic or the non-immunologic, non-allergic type of asthma, it represents about 90% of cases. It is more common in adult, as we call it adult onset asthma. This type of asthma is not associated with family history, no history of atopic or allergic disease. It is triggered by hyperreactivity or hyperirritability of the bronchial tree in response to infection, exposure to cold and physical exercise, anxiety and emotion, aspirin, and other inhaled irritant. This type of asthma has a normal serum level of IgG, but it is commonly associated with chronic bronchitis and nasal polyp. So to summarize the difference between extrinsic and intrinsic asthma, extrinsic asthma is more common in children associated with family history of allergy or atopy. There is no association of chronic bronchitis or nasal polyp, elevated IgE level with a good prognosis, and the allergen is the inhaled allergen as in house or plant pollen. While an intrinsic type of asthma occurs in adults with no family or genetic history of atopy or allergic disease, commonly associated with nasal polyp and the chronic bronchitis. The IgG serum level is normal. It occurs in exposure to infection, physical exercise, emotions and anxiety drugs, and inhaled irritant. The prognosis is bad for intrinsic asthma, comparison to good prognosis for extrinsic asthma. Pathogenesis of bronchial asthma. The key player in the pathogenesis of bronchial asthma is the CD4 helper cells. This type of the immune cells, it is the master regularity of the immune system. It is activated in exposure after exposure to antigen, but it doesn't directly identify the antigen. It needs the antigen to be presented by the macrophages through the MHC molecules. This class 2 MHC molecules or major histocompatibility molecules identify the allergen and present it through the receptors to the CD4 cells, which differentiate into CD4 T helper 2. So after exposure to the allergen presented by the macrophage to the CD4 cells, it differentiate into CD4 T helper 2. The CD4 T helper 2 in turn activates the B lymphocyte to differentiate and matures into plasma cells that it is responsible for production of the immunoglobulin. These plasma cells produce a large amount of the specific IgG immunoglobulin specific to the allergen. These IgG immunoglobulins bind to the surface of the mast cells and the basophils and stimulate them to produce their granules containing several mediators as histamine and serotonin. So on subsequent exposure, IgG bind directly to the IgE present on the surface of the mast cells and the basophils without requiring the macrophage identification and the stimulation of the CD4 T helper cells. These cells degranulate, releasing the mediators leading to the early phase of asthma. And later on, with hours passed by, they sensitize other mediators and release it to cause the late phase of asthma. So all of these pathogenesis, we call it type 1 hypersensitivity reaction as it is characterized by IgE production. So to explain the pathogenesis, an inhaled allergen into the airway will be identified for the first time by the dendritic cells presented through class 2 MHC molecules to the CD4 cells. CD4 T helper cells is differentiated into T helper T cells that cause the stimulation of the B lymphocyte to mature into plasma cells to produce large amount of allergen-specific IgG immunoglobulin. This IgG binds to the surface of the mast cells and causing stimulation of the mast cells to the preformed mediators that cause the early phase of asthma. This is another figure to summarize the pathogenesis. An allergen enters through the airway, identified by the surface of the macrophages, presented to the CD4 cells that differentiate into T helper 2, stimulate the B lymphocyte to mature into plasma cells to produce immunoglobulin E, bind to the surface of the mast cells to release their granules. Granules are either causing early or late phase of bronchial asthma. So, what is the difference between early and late phase? Early phase bronchial asthma means that it occurs within minutes after exposure to the allergen, from 30 to 60 minutes, while late phase occurs within hours after exposure to the asthma. The mediators of the early phase, as in histamine, leukotrienes, and the platelet activating factors, and these mediators lead to vasodilatation with increased vascular permeability causing edema of the bronchial tree, increased mucus secretion causing mucus plugs, and the bronchoconstriction. While the late mediators as the interleukins, interleukin 4, 5, and 13, and the major basic proteins. These mediators affect more and more of inflammatory cells and in mast cells and predominantly eosinophils. It leads to damage of the surface epithelium with exposure of the underlying nerve ending. And also this damage of the surface epithelium leads to easily passage of the allergen into the mast cell directly to the subepithelium. Exposure of the surface epithelium leads to recurrent attack of the asthma. Under microscopic examination, asthma is characterized by increased mucus secretion that can cause mucus plugs into the small airways. The surface epithelium shows goblet cell hyperplasia, thickening of the basement membrane by collagen deposition. There is a smooth muscle hypertrophy and hyperplasia of the wall, mucus gland hyperplasia. There is increased vascular permeability and edema. Also abundant of inflammatory cells rich in eosinophils with eosinophil-derived substances as what we call it Kirschmann spirals and charcoal-eating crystals. And eventually this leads to fibrosis. All these microscopic changes in case of bronchial asthma are known as airway remodeling, the changes that occurs in the airway in response to allergen. So this is to compare between the normal airway and the airway in case of asthma. Normally, surface epithelium pseudostratified columnar separated with goblet cells on a thin basement membrane. There is a sparse and few inflammatory cells in the subepithelium with a few mucus glands. In case of asthma, there is hyperplasia of the goblet cells, increase the mucus in the luminal surface causing mucus plugs, thickening of the subepithelial basement membrane with collagen deposition, hypertrophy and hyperplasia of the smooth muscle, hyperplasia of the mucus gland, dense inflammatory infiltrate in eosinophils, in addition to the eosinophilic derived product. Another diagram to differentiate between normal dilated lumen of the airway, in addition to the narrow lumen filled with mucus in case of bronchial asthma, the thickening of the wall with the muscle and the inflammatory cells and the mucus gland. This is what we call it Kirschmann spirals. These spirals are formed of mucus plug that is present inside the lumen, and the chocolate needle crystals are needle-shaped crystals that are formed from the byproduct of the proteins derived from the eosinophils. They can be identified in the mucus layer or in bronchoalveolar lavage. This is another imaging of the spirals of the Kirschmann spirals of the mucus plugs and the needle-shaped crystals of the charcoal-laden crystals. So if you want to describe a histologic sections of the airway in case of asthma, we can see here increased the number of the goblet cells, presence of mucus into the lumen, thickening of the basement membrane by collagen deposition, hypertrophy and hyperplasia of the smooth muscle, increase in number of the inflammatory cells rich in eosinophils, and if there is a deeper section, we can see hyperplasia of the mucus gland. So finally, the complication in case of bronchial asthma includes the other types of obstructive pulmonary airway, as in chronic bronchitis, Emphysema, when mucus plugs the obstructed sternal airway, causing increased pressure and destruction of the wall of the alveoli. The fibrosis of the lung with pulmonary hypertension that leads to right-sided heart failure. This right-sided heart failure caused by pulmonary hypertension, we call it cor pulmonaire. Status asthmaticus, this is a clinical term, means that attack of severe asthma that doesn't resolve. It can lead to death from respiratory failure. By the complication of bronchial asthma, we end our lecture today. If you want to more read about bronchial asthma, you can go to Robbins Basic and Robinson course in Pathology Basis of Disease. And if you have any questions, you can send me your question. Thank you.